Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Kate Leslie and I'm here with my co-host Mike Grocott at the combined meeting of the International Anesthesia Research Society and the Society of Critical Care Anesthesiologists in Honolulu, Hawaii. I've had a wonderful time so far, Mike. I've been to great plenary sessions, wonderful clinical trials workshops, and best of all, a really fantastic poster sessions here, over 1,000 posters. And they're old-fashioned ones on paper and cloth, so it's really been a fantastic meeting. How's your meeting been so far, Mike?
Well, as we talked about earlier, I've managed to get to 0 sessions due to my flight derangements with Heathrow Airport having a fire, being closed. So I've travelled to various airports around Europe and America in order to get here, and therefore missed most of the conference. And sadly missed the prehabilitation session, which I had been planning to talk in, that our secret guest chaired.
So we better get to our secret guest, who's Daniel McIsaac. Dan, welcome to the podcast.
Thanks so much for having me.
Can you tell us a bit about yourself?
So I'm a professor of anesthesiology and pain medicine at the University of Ottawa in Canada. I'm also a board member with the International Anesthesia Research Society, so I've been quite involved in the conference this week. I'm glad to hear you both enjoyed it. And I run a research program focused primarily on improving outcomes for older surgical patients, as well as running innovative clinical trials.
Excellent. And at the trials workshop and also in the main meeting, we were lucky enough to hear the results of your PREPARE trial. So what inspired you and your team to start this magnificent randomized controlled trial?
Well, I'd say most people I've met in the prehab space have largely come into it because their primary interest is prehab. Does my prehab program or our prehab program improve outcomes? I think we're a bit different that way. We came into the prehab space primarily with all the work we'd done with older surgical patients with frailty, looking for an answer to how do we improve outcomes for older patients with frailty. So that was really the genesis of PREPARE. We were lucky to find a great team of investigators with a lot of expertise in prehabilitation, from whom we've obviously learned a lot. And so we brought together a question around how do we get older people with frailty successfully through the operating room, and can prehabilitation be the answer to that question? Now, along the way, we had to do a lot of work on the prehabilitation side to develop the intervention, test it, etc. But it was really a convergence of those two things that brought the PREPARE trial to life.
So just for the background for our listeners, can you tell us a bit about frailty, what it looks like, how common it is?
It's funny you say what it looks like. What it looks like seems to be the one thing we can all kind of agree on. From the end of the bed, clinicians are reasonably good at understanding what patients they're concerned about because they have decreased reserve, they have multidimensional deficits, they're in that state of vulnerability that defines frailty. And certainly work that we've done, and great work that lots of other folks have done as well, clearly shows us that when it comes to the usual outcomes that we measure after surgery, 30-day morbidity, mortality, whether people get home successfully, those with frailty have a multifold increase in the risk of adverse events. At the same time, we know that these older patients, they want to get through that 30 days, but they want to get home and they want to be functional. And we were lucky enough to do some work around patient-reported outcomes and certainly found that, unfortunately, a lot of those patients were experiencing new disability after surgery as well. So it's clear that there are deficits there. We need to do something to try and improve their capacity to tolerate that stress of surgery. And perhaps with that, we can get those outcomes looking a little bit better.
So what intervention did you look at in your PREPARE trial?
Yeah, so much like frailty, prehabilitation is another, concept that has a lot of different definitions. So our intervention in PREPARE was primarily founded in exercise, but most importantly was delivered at home. And there were 2 key reasons that we delivered prehab at home. Number one, we're lucky to have a lot of patient partners on our team, and they were quite good at helping us to design that intervention. And they told us, we want this at home. We don't want to be coming into hospital all the time to do this work. Number 2, bigger James Lind Alliance patient priority partnerships. They've said the same thing. So we knew we needed to get this done at home, and to be scalable, that it had to happen at home. So we built it on a foundation of exercise, multimodal, so moderate intensity exercise guided by a Borg scale, body weight, modified body weight, and TheraBand exercises, as well as stretching. So that was done 3 times per week. We had a nutrition aspect as well. It was structured nutritional advice based on their personal malnutrition risk. We provided them with discounts for protein supplements and encouraged them to take it, but we didn't explicitly provide them protein supplementation. And then crucially, this was not a here's your prehab package, you go home and do the work type of intervention. This was supported by excellent coaches. Coaches really are a secret sauce of the work that we've been doing. They provided structured support to our participants based on theory-informed behavior change strategies to try and get folks to do the work we knew they'd need to do to get better outcomes after surgery.
So then, I as you know, do a bit of prehab work with the great team we've got in Southampton. We'd kind of come at this a different way because, as you said, you came into it by frailty. We came into it by the exercise literature. and initially did some proof of concept work in hospital, and then we were heading into the community. And where we've pretty much stopped is in the community but not at home. I just wondered whether in your thinking in setting up the study, how much you considered right at home or near to home for the intervention.
So we certainly considered that. I guess the other piece in this is geography. So I'm from Canada, and our population is quite geographically distributed. You know, if you looked at how many people lived in the distance between you folks in Southampton and London, if that distance was in Canada, not very many. So for a lot of our patients, we just don't have a community-based facility that they could access. So that was definitely a conversation for urban populations, perhaps, and we have lots of urban populations in Canada. But considering those who probably need this most often are in that urban environment, we did focus in on, let's see how we can deliver this at home effectively with good, safe coach support.
Yeah, I mean, we're urban and rural, but we're British rural, which is much higher population density, I know, than Canada.
So in Canada, the average patient lives about 90 clicks from the nearest specialty oncology center. For example, a lot of our patients are surgical oncology patients, and that's just not going to work. Yeah,
sure.
What's the underlying fitness of the population that you're planning to study, and also the underlying rate of nutritional issues, in particular malnutrition?
So, it's remarkable on the nutrition side. We need to do a lot better job on the nutritional epidemiology around surgical patients, I think, in general, and those with frailty specifically. So we're quite fortunate to work with Chelsea Gillis, who's a world leader in prehab nutrition. And certainly, Chelsea was able to help us identify that most of our patients were probably in a pretty significant protein deficit prior, to coming into the program and into surgery. But malnutrition risk, again, lots of different ways to assess it, but we knew our patients were generally going to be in deficit there. And the other piece is we've done quite a bit of observational work previously on what drives disability after surgery for our patients. And it really was primarily lower limb strength, muscle loss, and that type of thing. So we knew that exercise was going to need to be a key piece of that. Their DASI scores, for example, were certainly, above any threshold that's been identified on average in terms of identifying those higher risk of complications after surgery, along with the frailty.
So that's the Duke Activity
Status Index.
For our listeners, and you can get that on apps quite easily, can't you?
You can, yeah.
Yeah, but our listeners are probably dying to know the results of the PREPARE trial. Are you willing to share that with us?
Absolutely, be happy to. And so these results were presented this weekend at the IARS conference, as we discussed before. They're under review. So just to frame it out very quickly, this is an 850 patient randomized control trial, which takes place at 13 different centers, basically from coast to coast in Canada, academic hospitals, as well as community hospitals. For patients to be enrolled, they had to have frailty based on a clinical frailty scale score of 4 or higher, which is done by a trained assessor. And they needed to be having basically major thoracoabdominal, pelvic, or vascular surgery on a planned basis, with at least 3 weeks of expected time to be in the prehab trial. We've discussed the intervention already, so folks were randomized to that or to usual care. And our trial was powered to have 2 primary outcomes or co-primary outcomes, which we won't get into the stats, but we accounted for that in all of our analyses. So the first was a patient-reported disability score 30 days after surgery, the HUDAS score, which I know you folks are well familiar with, and some of our listeners maybe. Patients love the HUDAS score. It means a lot to them. Our patients certainly do. So it reflects how well they're doing in their day-to-day life. The second primary outcome was the incidence of any complication after surgery. So cardiopulmonary, infectious, etc., the usual things that you'd expect to find. And so what we found was when we randomized individuals to prehabilitation or usual care, we did not find a significant improvement across all patients in terms of their patient-reported disability scores. They were slightly lower in the prehab group, but that was not statistically significant. And there really was no difference in complication rates either. And listeners may be surprised by this because lots of data are out there on prehab, including from our team just a couple of months ago in BMJ, showing large effect sizes from prehabilitation. But those large effect sizes we've seen to date have been in mostly small single-center studies, resource-intensive, motivated patients coming into hospital to do this work. This is one of the first trials that's tried to expand prehabilitation out to health system level, which leads to the other important finding, which is that when you do look at the individuals who perform an adequate amount of prehabs, who complete at least 75% of the program, we do see minimally important improvements, so clinically meaningful improvements in disability scores after surgery. So at a system level and an individual patient level, we have somewhat discordant results.
So that's like the intention to treat analysis was negative, but the as per protocol analysis was positive.
Exactly.
It's interesting, though, are patients who complete exercise programs like this different to patients who don't?
So they are slightly different, and you always have to interpret those per protocol analyses carefully because you'll lose some of that protection of randomization. So you need to consider a number of different factors in that. But certainly if you look at the baseline characteristics of those who completed per protocol the intervention versus those who didn't, they were slightly healthier, which would lead you to expect them to have slightly better outcomes.
Did you look at socioeconomic type determinants of adherence?
So we're right now, a main part of our research program is focused on this question of adherence, because what we see in this, any other trial in prehab that's been done in older patients with frailty previously has almost identical to results to that we have in this larger trial. Intention to treat analysis does not show a difference. Per protocol analysis shows minimally important differences. So adherence. We step back out of perioperative medicine, exercise, good nutrition, those improve health status. So it's not if this stuff improves health status, it's how. How do we deliver effective programs that an adequate number of people are going to take up and therefore gain benefit from it? So we actually have collected very detailed adherence data every week on what leads to prehabilitation adherence are. So the ones that we found, number one, scheduling. We had patients who we understood were going to have 3 weeks before they came to the operating room, but sometimes they had surgery sooner, more often than we did, partly because this was during the COVID recovery phase. These are oncology patients, so they were really getting prioritized to go to the operating room. We had symptom burden. Older people with frailty often have symptom burden related to the reason that they're going to the operating room. So we definitely had patients who just were too tired, they'd had neoadjuvant therapy, etc., to really press hard on the program. And then, let's be honest, you don't end up in later life living in a state of frailty necessarily because you've had the best health behaviors through your lifespan. So this is a big change in a short amount of time that we're asking people to do. So there are barriers related to that as well. So we're quite excited to look into what the keys are going to be to overcoming this adherence barrier to try and unlock this. Because I know, we just spent 5 years running a trial. We're disappointed that we didn't show a bigger result, but we consistently see the promise of prehabilitation, which, most others do as well. So we got to get together on this and figure out how do we make this happen effectively? Because that's what our patients want.
Our adherence levels are very high, but as you've rightly commented, we were initially in hospital and then we were in the community with direct one-to-one supervision or occasionally one-to-two. What was the coaching? So was that on the phone, in person, every time, occasionally? So how did that work?
Yeah, so when we wrote this protocol, I think in 2018, we talked to our patients and basically we'd surveyed a bunch of them. 1 in 5 said that they were comfortable with information technology. And basically 5 in 5 said, we don't want to do this on the computer. So this was phone-based coaching. Now we had excellent coaches. All of them had either exercise kinesiology training or nutrition science training. We did a lot of work to train and maintain standards within that. The way the coaching intervention worked was basically that there was an intensive teaching session on how to do the exercises and personalizing those exercises, whether it's musculoskeletal challenges people had, pain issues, whatever it is, how can we personalize your exercises to let you do them? Then at minimum, they'd be in contact with the patients weekly. They had consistent relationship with the same coach throughout that period of the program. And, we'd check in on adherence. If adherence was not at 100%, we'd identify structurally what the barriers were to patients not achieving the adherence we'd hoped for. And then we had evidence-based strategies to try to link up with that, to say, okay, you're having a lot of symptom burden. Let's talk about that. Let's figure it out and see how we can break this up or make it work, or how do we modify your exercises? So patients could also call in if they had concerns and challenges of their own. So I think it was pretty robust from a coaching perspective for home-based intervention, but without question, we didn't have a wearable on them. We couldn't see the real-time data. They didn't want to be on Zoom. I think 2018, we weren't on Zoom all that often, right, compared to now. So there's all kinds of, again, pieces of the puzzle that remain to come together. I think at that point, that was what our patients wanted and what we could do. In the trials we're running now, we've changed the game up a little bit for sure.
I guess, the technology acceptance levels, partly because the old people are grown up with it.
They're different.
They're a different cohort of old people.
And cohort of older people.
And obviously because of COVID, I think are becoming very different.
Yeah.
Interesting to see your future studies, but also the kind of gap between, I think, what we're doing, which is quite expensive and quite resource intensive. We're all showing that biologically it works. If you can get people to train adequately and get adequate nutrition, they'll get fitter, they'll do better. Surprise, surprise. It's just it's the implementation.
It's the how.
Yeah, that's the real challenge. Maybe it's, horses for courses, different interventions in different geographies for different types of people. Yeah. Those that can travel, those that can't.
Yeah. That personalization aspect is going to have to advance further. I think that doing more large randomized trials to do our best to implement and have effective programs is actually going to give us the data to then understand how do we continue to refine program design. So some of them are going to be large randomized trials like the one that we've finished, the one that we're running now called Strive. And then it's also going to be other designs, and this isn't a trial design podcast, I know, but there are other things like smart designs where we can do multiple changes along the way, trying to drive adherence instead of outcomes to understand how we can get that done. So that's stuff we're looking at as well.
And a platform type approach. And I know it's not Trial Geeks United, but I think actually the platform approach is in some ways more accessible to people, rather than we're going to spend 5 years doing this big trial and then at the end of it.
Let's just say it, be a little disappointed.
A bit disappointed. Sure. We can incrementally improve, and we can, for example, add in strength as well as aerobic exercise or take it out. It feels, although more complicated, are actually more acceptable and credible to clinicians.
And let's be honest, our patients unquestionably want this. The patients that we had in the intervention arm, I've gotten more Christmas cards from them than I have from family members. And my family members like me, don't get me wrong, but they're so happy. They feel cared for. They feel like someone has taken them under the wing during that stressful time before surgery and cared about them. And that has a value in and of itself, but obviously we want to enhance and extrapolate that value into something larger. But, we recruited 850 patients through the COVID period. Every week, patients from all our centers. Patients wanted to be in this trial. 86% of patients who were eligible for this trial said yes and enrolled.
That's very high.
That's very high, yeah.
Yeah, I mean, we see the same. And in fact, I don't know if you had this, but our principal obstacle when we started doing it was the oncologist, not the patients, because the oncologist kept telling us it was just not possible. Their patients were far too busy and far too sick for it. And the patients have always lapped it up, really been very popular.
And I'd say from a trialist perspective, the biggest challenge is the disappointment of not being in the intervention group. We did we worked with patients to understand how we could maintain blinding and do all that kind of stuff. But, patients, that's the problem. If we were to do this in an observational setting without randomization, patients are differentially motivated when they know they're going to get the program. So that's a bit of a barrier sometimes as well. Yeah.
So this is actually Trials Group Geek United. How did you put together your coalition of centres?
Yeah. So, we're fortunate in Canada. We have a national clinical trials network called PACT, and they were instrumental in helping us to put that network together. But, along the way, surprises come up. So we went in and we got a generous funding envelope from our national funders, CIHR, along with some local funders. And then we started getting emails from centers saying, we heard you got funded. We'd really like to be part of the PREPARE trial. My collaborator, Susan Lee at the University of BC, and her team, they weren't part of the project to begin with, and they ended up being the second highest recruiting site for us. And we had some other sites who keenly came on board as well. So, along with the patients, did we ever get any pushback from surgeons? No, never. They were happy to get their patients into a prehab trial. Again, patients were happy about it, and our anesthesia colleagues were happy to see that we as a specialty were driving a driving force around intervention like this in perioperative medicine.
Were they all university hospitals, or were there community hospitals as well?
Yeah, there were community hospitals as well. So we had some smaller community hospitals in Ottawa where we're located. And then in Canada, we have core academic hospitals, and then we have affiliated academic hospitals to a certain degree. So we had some of those affiliated. We had a really nice generalizable, I think, for most context, representation of centers in our trial.
Because lots of anaesthetists who are working in affiliated or other hospitals love to have a bit of research going on around them, or that they can contribute to. It's like the patients. It gives it meaning to their work and to their presence in the hospital.
And we deliver that intervention centrally too. So we weren't asking centers to prehab their patients. We were asking for centers to support their patients accessing the trial and the program. We did it centrally. It was, every trial is hard, but it was relatively easier on that part, which was nice to get them in.
So Dan, I know we're principally talking about the PREPARE trial, but I really like your systematic review in the BMJ just after Christmas, and particularly because of the teasing out of the different interventions, which I read as broadly saying that exercise seemed to work and that there was maybe some synergies with other things, but it became a little less clear. And I just wondered if you had the opportunity or were able to collect the data in order to address that question within the PREPARE study as well.
The question of
in terms of sort of relative adherence to the different interventions and therefore the effect on benefit.
Yeah. So, within the PREPARE trial, we had exercise was our main indicator of adherence. Because we didn't have satchels of protein going out, the adherence from that perspective. I will say, one thing that we learned from the PREPARE trial is that structured nutritional advice, although good, isn't good enough. And I think especially for this population, as we move forward, we provide protein supplementation now for all of our prehabilitation patients, high quality, low symptom burden, and we can achieve high adherence with that whenever we partner with patients to do that piece of it. And then the exercise piece of it, I think this is the question, every time we give a talk on prehabilitation. I'm sure you experience this as well. How long is long enough? And the best answer I can give you is we don't know. The exercise physiology literature would tell us maybe in 3 or 4 weeks, we can start to move the meat a little bit. We're not going to be able to build a lot of muscle mass though, but maybe it'll make a difference. We had primarily oncology patients. Certainly for us, we have a 4-week diagnosis to operating room time. So that's the most time at this point that we're going to have to get somebody prehabilitated. So we got to work within those constraints as well. But it is interesting to think about the different layers of program delivery and how you start to structure that around those requirements.
We moved, because of some of the challenges of getting nutritional assessments, we moved to, if you were high risk on a nutrition risk score, we give a protein supplement immediately.
Yeah.
And then maybe a week later or whenever you get your nutritional assessment, you can have a more finessed intervention. I mean, certainly our experience with time, and some of which we've got from the patients who don't go straight to surgery. Well, some of it's because of the inefficiency in our system, which is a shame. But some of it, the patients who are having neoadjuvant therapy, for example, who may have quite a long time to surgery, is once we get past 4 weeks with the cardiopulmonary exercise testings, we're clearly seeing an improvement in fitness, which plateaus a bit by 6 weeks in truth.
Yeah, and then on the other side, by 12 weeks, we find patients just don't have it in them to keep up the regimen. They start to lose their wind. So there's that other end of it too, which is interesting. Yep.
They're human, aren't they?
They're very human. And that's crucial. And so, the behavioral motivators are there and trying to turn those levers. And then there's the structural aspects to try and optimize how we deliver all this stuff. And that's all got to come together. This is not, if we could put prehab in a syringe pump and run it in the operating room, we wouldn't have to have this conversation. But obviously that's not how it works.
They're just like the rest of us in normal life.
Absolutely.
You exercise sometimes it just doesn't work.
Exercise is hard.
Yeah.
It is.
Well, we should leave you to get out and get some exercise in the beautiful sun of Honolulu. Thanks so much for being on the podcast, Dan.
Thanks for the invite. It's always great to chat with you folks and to chat about prehab.
Yeah, great to talk to you, Dan. Thank you.
So you can find this podcast on our website. You can go to YouTube, where you should give us a big thumbs up. We're also on social media.
And of course, we'd like to thank our sponsors, without whom we couldn't bring our content free and open access to the world. And that's BD and GE Healthcare. Thank you very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.